I hope it's recording. Yes. I just opened it. So this wasn't on, it wasn't, you couldn't see it until just a minute ago. Okay, you guys quiet. I hear lots of mumbling and I can't, my brain fuzzes out. So, okay, so we're gonna go over commonly missed questions on the exam. This is really important because you may see these in an upcoming quiz. These are questions that are not on current, that's not going to be on normally I'll say in Moodle, I'll say the quiz is going to be over chapter 11 or chapter whatever. But because this is all important stuff that you may need for a final or and there was enough people missed it that I'm probably going to hit them again on future quizzes. So I don't know if they'll all come on one quiz or two, they'll trickle in. But take note because you'll see this again. Okay, so, oh, I'm on the wrong. Here we go. Okay, so drug interactions. I didn't love this. I had changed this question from how it originally was. And I had changed some of the information on the with adverse reactions and drug interactions and things like that. But on one of the slides, it says drug interactions, they're adverse effects. And then I kind of put in toxic side effects. So I added a few verbs there or whatever, I don't know, words. When certain drugs are given concurrently with another drug, an herbal supplement, or food. So you get an interaction and oftentimes it's adverse. So if you take, so they have to be careful when they're prescribing two different drugs that you take at the same time. They have to make sure that there's not a lot of interactions that are adverse. It can happen with milk, can change your absorption of things. Grapefruit juice can, it does something to enzymes. It's like it uses up the enzymes or it inhibits the enzymes, I think, grapefruit. And so it makes certain drugs have a higher not toxicity, but a higher level in the blood. So so food and then herbal supplements can do it as well. There's a lot of herbal supplements that can increase bleeding. So those are the kinds of things that they're talking about. So I think the fill in the blank that I was looking for was like side effect or adverse reaction for this specific question, but originally the fill in the blank was drug interaction was the fill in the blank. I didn't love the question, but I just thought we should talk about this just a little bit more so that you kind of had that in your minimum effective concentration. So this is another important thing to know. When you start taking a medication, it takes a while for it to take effect. Once you start to get a therapeutic effect of any kind, that's the minimum effective concentration. It's the least amount of medication that you can take and still get a therapeutic effect. Now there's a range, there's a therapeutic range. And so this is going to depend on different people and their needs and what they take the medication for. And then you're going to hit this toxic concentration. Too much of anything is not a good thing, right? You can drink too much water and get sick. And so like there's a toxic concentration. And so that's basically this therapeutic range is where we want to keep our patients. So minimum effective concentration. Some people put minimum effective dose, and I just gave everyone the point because I just was like, this is kind of just a needle in a haystack and I just wanted to revisit it. So. Critical thinking question, if a drug is highly protein bound, will it require a higher or lower dose of the drug to have an effect? When drugs go into our bloodstream, they're either free and available, bioavailable, or they get bound up by protein. And some are more highly bound by protein and some are less bound by protein. But basically, if something is highly bound, there's not as much of the drug. So typically the answer would just be you'd need a higher dose. What else can affect protein bound drugs? Again, some medications are going to kind of be bullies and they're going to take up all of the protein, and then the rest of it's going to leave the other drug to be more available. And so that drug might have too high of a concentration. So they have to think about those things. How protein bound is one drug over another. Foods and herbal supplements can do this as well. Distribution, passage of drugs through, so this might, I'm not sure what question this, but it might have just still been about protein bound, I'm not sure, but just to review this slide, passage of drugs through blood plasma to the site of action. So they go through the bloodstream till they get to the tissue that they're going to work on. Drug is carried through the blood in either free, and that produces the effect, the free floating drug produces the effect, or it's bound to plasma protein. So we kind of said that already. And then what is diabetes? So 3 possible reasons that somebody can have diabetes. They don't make insulin, or they have too little. Usually it's that they don't. Sometimes with type 1, they can have a little, but then it peters out, and then they get to the point where the liver releases too much glucose. So there's too much glucose coming out of the liver, or your cells are not utilizing insulin well. So you have pretty much those 3 major things. So that was one of the questions on the exam. And so just whittling it simply down to those things. You're not using it well, you don't have it, or the liver is producing too much glucose. Those 3 things. Hyperglycemia is the main manifestation of a lot of the comorbidities and problems that come from type 2 diabetes and type 1 diabetes as well. So it's hyperglycemia is that if they're chronically in a state of high blood sugar, there's going to be kind of a cascading event of negative things to nerves and blood vessels. And so that is that. A couple people were asking me about it during the exam, and I was trying to like help them but not say it. It's like that's the trigger. That's secondary to the problem with insulin. You know, the first problem is they got a problem with insulin. Either they don't have any or they can't use it. But because of that problem, they have hyperglycemia. And hyperglycemia causes all kinds of bad stuff. So does that kind of make sense? Now, don't get that confused with the most common medical emergency. So people who are taking medications to help them with their diabetes, oftentimes if they're gonna present with a medical emergency, it's gonna be hypo. Gets confusing, and that will show up on an exam sometime in the future or a final. So, and the reason why is because they're taking a medication, they're taking insulin, they're taking something, and then maybe they haven't eaten, maybe they're under a lot of stress, and all those things can burn up their glucose, or they don't have any because they didn't eat enough glucose, but they got all kinds of insulin or all kinds of a medication that increases insulin production or sensitivity or something, whatever kind of medication they're on. And so then they're at risk of hypoglycemia. People with hyperglycemia get used to it. It's not healthy, and they're not healthy, but they get used to it, so they don't feel sick. But if you're hypoglycemic, you feel sick pretty darn fast. And hyper can get critical as well. It's just that most people kind of live at this elevated state if they're poorly controlled, and they don't really feel that bad, even though their body is not happy. But it's kind of like high blood pressure. You can have high blood pressure and not feel too affected by it. Okay, and then just a reminder too, glucose is a sugar that's taken up into the cell by insulin. So insulin is like the key that unlocks the cell and allows glucose to come in. So it's just a kind of a simple analogy. Insulin's the key, opens the cell, glucose comes in. Insulin is a hormone made and secreted in the pancreas, the beta cells of the islet of Langerhans, but that's in the pancreas. So that's another important thing to remember. It's in the pancreas. And that was it. Do you guys have any questions on those reviews? Questions? So just keep all that information floating in your brain, and it'll pop up on quizzes in the next couple of weeks, and then also potentially on the final. I can't remember exactly what questions of those are on the final, but I know that that's all pretty important information for you to have. Okay, so then let me just switch now. Yeah. Yes, it could be two medications coming together. You know, a food that they say don't eat or don't take this with food at all, or take it with food, you know, things like that. Any kind of those kind of instructions. Okay, so just as a reminder, the PowerPoint from Dr. Beggert from last week, that is fair game for quizzes and exams. And I'll try, a lot of times he'll highlight on any of the guests, because we have several guests, they'll highlight medications. And so it's not like the laundry list of possible medications. They'll highlight some, and those are usually the ones that you'll see come up on a quiz or an exam. So, because sometimes it can be overwhelming, like how am I going to memorize all of these medications and their mechanism of action and blah, blah, blah. So we try and kind of highlight it. A lot of times questions will say something like, you know, it might say, for example, calcium channel blockers, a high blood pressure medication, but also a medication that's used for other heart conditions. So calcium channel blockers, they're the ones that's most common to cause gingival hyperplasia or gingival enlargement. So on a quiz, and also they end in pine, P-I-N-E, the calcium channel blockers do. So some random calcium channel blocker might show up on an exam along with 3 other drugs, and then it says which of these drugs causes gingival inflammation or gingival hyperplasia or gingival enlargement, however it's worded. And what if you know that the blood pressure meds that end in pine cause gingival, it doesn't even matter if you know every single one of the calcium channel blockers. You see what I'm saying? Like, as long as you know that suffix, and you know calcium channel blockers end in P-I-N-E, calcium channel blockers cause gingival enlargement. Like, as long as you kind of know that, you don't have to memorize every single one. So that kind of thing will help you, I think, with some of these medications. But okay, let me pull up the PowerPoint for today. I'm gonna stop share and then share again just to make sure it's sharing the right thing. Yeah.
When you say when they highlight it in the lecture or when they're here, does that mean that it's on the PowerPoint highlighted?
It might be like in red. So when I say highlighted, I mean, he might have put it in like a different color font. Sometimes I actually highlight things with like, I'll highlight it in the PowerPoint, but it might be highlighted like with a different color font. Yeah. Okay. These are the objectives. We're going to go over these cardiovascular conditions: hypertension, heart disease, angina, congestive heart failure. I did notice that I don't think he talked, oh, I don't want to go back. There was 4, hyperlipidemia. So that's what he covered. He covered hyperlipidemia medications. And here I have congestive heart failure. So, but we kind of, the hyperlipidemia sort of gets absorbed into these 4. So it's still in this PowerPoint. It's just that he sort of blocked those 4 conditions and then talked about the drugs specifically for those 4 conditions. And then explain the role of cholesterol that it plays in the heart disease. So we've kind of, that's sort of our part for in this PowerPoint slide. Yeah. It's not specifically, it's the difference between this set slide deck and his, is that I have congestive heart failure and he had hyperlipidemia, because he had like 4 outlined and my 4 outlined are slightly different. So I was trying to figure out why that was. And then I realized that in this slide deck, atherosclerosis and cholesterol and hyperlipidemia is just sort of absorbed into the talk of the cardiovascular diseases. So it's in there. It's just not, the objectives aren't really kind of piecing it out the same way. Okay, so the cardiovascular system. So this slide deck is kind of just an overview of the cardiovascular system and that some diseases, and then the medications are more highlighted in his. So the heart and blood vessels make up the cardiovascular system. Now, what are the function of the cardiovascular system? So in general, obviously, it moves oxygen and nutrients around in the blood. It gets rid of carbon dioxide out of our system, out of our body, protects us against disease and infection. We have our, our army of white blood cells, stops bleeding and injury, clotting. We have the platelets and the fibrin and all the whole system that's the clotting system. Removes waste products through our kidneys, and then transports hormones and cells, transports hormones to cells and organs. So it's a transportation of getting things where they need to be in the body. So lots and lots of super important purposes for the cardiovascular system. So we consider that the system has failed, basically, when the heart doesn't contract sufficiently, if it's not pumping strong enough and actually moving blood around the body, or if there's some kind of blockage or something, that's another reason why blood might not be moving effectively, is because there's a blockage. So that would be the atherosclerosis, and there's actually some kind of plaque buildup. A little bit of a side note, arterial sclerosis and atherosclerosis are similar. Athero is specifically talking about plaque buildup. Arterial sclerosis is like the hardening of the arteries. So as we get older, like our blood vessels are supposed to be real pliable and soft and bouncy and stuff. And as we get older, they tend to stiffen up. And they might stiffen up more in someone who has disease. But we talk more about atherosclerosis with the plaque buildup. But there is, if you've ever noticed those words are similar but different, that's the difference. Okay, and then cardiovascular disorders, hypertension, heart disease, angina, congestive heart failure, like we said we were focus on. So first we'll look at hypertension. It's defined as sustained elevation in the pressure in the arteries is sustained, pushing against the walls of the blood due to either the amount of blood in the vessels, there's a large amount, it's pushing against the sides, and there's just not enough space, or because the vessel has shrunk down. Let's see, the force that's applied to the walls of the arteries is the measurement you get when you take someone's blood pressure. So, whatever it is, 120/80, you have your systolic, that's the maximum pressure. And then the diastolic is when the vessel relaxes. How relaxed is the blood vessel? And what's that number? So if it's not very relaxed, that number is going to be high because there's still a lot of pressure in the vessel. So that's what they're thinking about when they think about the two numbers. So when I was in school, they always said the systolic is not as important as the diastolic, but now I hear them say different things. Now I hear them say the systolic is more important than the diastolic. But I always thought, you want everything to eventually relax. If it gets a little strung out, fine, but as long as it relaxes. But now there's different thought processes on that. So hypertension, according to the CDC, high blood pressure was a primary or a contributing cause of death for almost 500,000 people in 2018. And that's pretty doggone crazy when you think about it. When you think that in this pandemic, we've lost about 900,000 people to COVID in the course of the whole pandemic. But in 1 year, they attributed high blood pressure to almost 500,000 deaths. So it's pretty up there. We have a lot of issues with high blood pressure in the United States. High blood pressure costs the US about $131 billion each year. And that's averaged over 12 years from 2003 to 2014, they averaged the amount. Yeah.
The notes are underneath the image and it's there.
What? I never know what you guys see.
Oh, I know. I'm like,
That's so strange. Well, it's actually the next picture.
So it just covers it.
That's so bizarre. I don't know why that did that. No, you guys do not need to know those numbers, like the numbers from the CDC. You don't need to know those numbers. That is just sort of, in special needs, we talk a lot about etiology and prevalence and things like that. And it's really more, it kind of helps you with your holistic understanding of an issue or a disease or of whatever we're talking about. But I don't test on that because that's just way too, and it's always changing. I mean, it's going to be different, you know, from one year to the next. So did you guys ever watch, this picture was already in this PowerPoint, whoever originally made this PowerPoint, but I love this movie, so I kept it in there. Did you guys ever see WALL-E? He's so cute. I love WALL-E. I know that they have those chairs, they just float around in the chairs. Well, what was his little friend? Eve. Oh, Eve. I just love that one. Okay. All right, so we're gonna review just a little bit the receptors. So when we're talking about medications that are cardiovascular medications, we're talking about medications that predominantly work on alpha-1 and beta-1. Alpha-1 because they're focused on blood vessel smooth muscle, and blood vessel qualifies as that. So smooth muscle for alpha-1. And then for beta-1, it's the heart muscle. So not the vessels, but the actual muscle of the heart. And then also the kidneys. So it has to do with the kidneys releasing renin, which is part of that RAS system that you guys saw a little bit about that last week. So alpha-1 receptors are located in blood vessels of the heart, causing vasoconstriction and increased blood pressure. Beta-1 receptors are located on the heart muscle and affect heart stimulation and renin secretion. I have heart, on beta-1, I have heart, muscle, and blood vessels. Huh, I put that in my notes, but I didn't remember that. Maybe I'll just double check it. I'll take it out of my notes if it's wrong. Maybe I just forgot. I thought it was just cardiac muscle, but maybe it's also blood vessels for beta-1. I'll have to go back and check. Alpha-1, so there's animations in these that I don't know. I think that's why that picture was over it, because it's and I don't even know it's an animation because I don't look at the slide deck that way. Presentation. Yeah, I'm like, I don't even know that it's an animation, but that's kind of, it's nice unless it's blocking something you're trying to see, then it's not. Okay, so that's just, so beta-1 receptors with the heart is going to affect the contractility. So how strong your heart is going to contract. And the rate, the speed. Hypertension, as the body's demand for oxygen increases, so this is why naturally your blood pressure would increase for a good reason. As the body's demand for oxygen increases, the blood vessels contract or they dilate depending on what you need. So your body responds to what you're doing to give your body more oxygen or to direct blood flow where you need more blood and oxygen. So hypertension is when the force of the blood pumping through the arteries is too strong and it's sustained, like we already talked about, it's staying elevated. And then factors influencing blood pressure, this is important, a good little star area, is that the things that are going to influence the high blood pressure is either your cardiac output, so how well your heart is pumping, peripheral resistance of the blood vessels, and then blood volume, how much blood is inside of the vessel. So those are three things that'll probably show up somehow on an exam or a quiz. So I just have here in my notes. So for example, when you're working out, you need more oxygen to your lungs or to muscles, leg muscles, whatever, because you're working out. The blood vessels will dilate to allow more blood flow to that area, but the blood vessels, say in your stomach, for instance, will contract, slowing blood flow down to that area because it's not as needed. You don't need as much blood in your stomach when you're working out. You want it more in your muscles and your lungs and things like that, your arms and legs. If your heart is not pumping effectively or not pumping enough blood out, that will affect blood pressure. So if you're not contracting well enough and it's like pooling or backing up, that's going to affect blood pressure as well, along with overall blood volume or how much blood you have in your entire circulatory system. So of course, that would, here's that RAS system again. And I know this can be very overwhelming, but he described it so much better than I could ever imagine or hope to describe it. But some of the things that I want you to take away from this, and I have quite a little chunk of notes written on the side, and you can go on and you can like Google videos on the RAS system and watch different people doing explanations. And some people explain it really beautifully and can simplify it. And the more you kind of look into it, the more it makes sense. But the things to really look at this here are, you want to know that kidneys are an organ that affect blood pressure. Sometimes we just wouldn't think our kidneys have anything to do with blood pressure, but you want to know that. And that has to do with that renin production there, how it excretes renin. But we start with the liver. It's in response to your body's needs. The liver will produce this angiotensinogen. So that's the first chemical or hormone that comes out. And then it's going to go through a series of changes before it gets to this angiotensin 2, which then affects several systems. It affects the sympathetic, it affects sodium, absorption and excretion. And then it affects the pituitary gland and arterial vasoconstriction. So it has if it goes through its system undisturbed and it goes through its transformations, it affects all these systems. But if we're trying to control blood pressure, then there's a couple medications, just like he said, ACE inhibitors that come from the lungs. We have our ACE receptors in the lungs. So if we're gonna inhibit those receptors in the lungs, we're gonna give an ACE inhibitor. So knowing that that stops the transformation from angiotensin 1 to angiotensin 2. So you can kind of do a flow chart. We start with angiotensinogen, goes to, when we get the renin, it goes to angiotensin 1. And then once we get the ACE, it goes to angiotensin 2, which now it can affect many systems. So a doctor may give ACE inhibitor to prevent it from converting from angiotensin 1 to angiotensin 2. Then, like he said, there is a second medication that you can use called the ARBs, and they're going to block the angiotensin 2 receptors. So then they'll stop this downflow. It'll get to this stage, but it'll block the receptors, so you won't get all of these increases here. So that's the most important thing of this big old thing, is to really know some of these organs, that are involved. So we know it's the liver, kidneys, and the lungs. Most importantly, knowing renin comes from the kidneys. So kidneys have a function in blood pressure. ACE receptors are in the lungs. So we want to inhibit those receptors. And then that stops angiotensinogen from going from angiotensin 1 to angiotensin 2. So those are some of the key points. Any questions on that? It's a lot. You're like, can you say it all again? Just repeat.
So you're saying that ACE inhibitor is given or advice to A1?
An ACE inhibitor drug is going to inhibit the ACE receptor. So it's gonna make it so angiotensin 1 doesn't convert to angiotensin 2. which angiotensin 2 is the one that does all the stuff. Angiotensin 2 is like the one that's like the final drug that chemical in your body that does all these systemic changes and causes blood pressure to be higher. So an ACE inhibitor is going to block those ACE receptors in the lungs. And so it kind of puts a full stop on the system.
So does it, like, for example, get the blood pressure to a normal level without having a high blood pressure?
Yeah, well, the medication helps to lower blood pressure because this whole system raises blood pressure. Like if you just leave it, this whole RAS, renin, angiotensin, aldosterone system, its whole purpose is to raise blood pressure. And usually it does it in a very normal way for people who need their blood pressure raised, and then for it to, like if you're healthy and it works in it. But if it's too high and you need to kind of stop this system, that's where you take an ACE inhibitor. That's the drug. Mm-hmm.
Okay.
Yeah. So the ACE inhibitor is the medication that kind of does a full stop between angiotensin 1 and angiotensin 2. And then the ARBs, which we don't talk about as much, but they're out there, they put a full stop. You have the angiotensin 2, but they put a full stop and they don't reach all the receptors in your body as well that are the angiotensin 2 receptors. So it's an ARB, angiotensin receptor blocker, ARB.
I'm sorry, where do we get the ACE inhibitors? Are they like medications taken?
Yes, ACE inhibitors are medications, and we'll look at those again. Or if you go back to, actually, I don't think we look at them so much in this slide deck, but when you look at Dr. Beggart's, he has a really nice, and he highlights the suffix. So like the olols and the prils and the preen, those are the suffixes for these different categories. Sartans, I think the ARBs are sartans. So go back and make sure you look at these suffixes and how they relate to these different categories. That's definitely going to be test questions. Not so much specifics on drug specifics, although like I did talk about earlier with the calcium channel blockers, you might be able to identify them per some common side effects, but that's really important for you guys to know the suffixes that correlate. Okay. Yeah. Well, and it's different medications too, like diuretics get rid of fluid, and so people, it's hard to get people dialed in just right. Like my dad has high blood pressure, and so he went way too low. They gave him a medication. They're like, try that. He thought he was going to pass out every other second, and his blood pressure just went too low. So it's really hard to dial people in, and so sometimes they use combinations. They might use a diuretic. There's different types of diuretics, and they might use one of these medications like an ACE inhibitor. Calcium channel blockers that tend to just dilate the vessels. So that might work better for somebody. So it really is just figuring out what each individual needs. It's not necessarily this specific thing that's causing it. Yeah, it could be a different medic. I think I am, yes. Does it look like I am? Oh gosh, yes, I am. Go ahead. Yeah.
So I was looking at this kind of study guide, based on this. What organ does
it would be. I think what they're looking for is kidney, though. I think kidney plays a key role because kidneys have the renin, which is super important to get angiotensinogen to. So I think the kidney is the answer to that.
Okay.
Mm-hmm. Okay, so 90% of people with hypertension have no identifiable causes. These are some risk factors, and they're usually kind of lifestyle related, although sometimes people can get high blood pressure just as they age, even if they have like my dad actually, he smoked for years and years and years, but he quit when he was in his late 50s, and he didn't get high blood pressure till he was closer to late. It probably had to do with years of smoking is probably what his was. But in general, between that time, he's super healthy. So sometimes it's just age, but it can also be lifestyle. Yeah, go ahead, Ian. It's kind of mixed in. They're kind of mixed in there. So some of those questions, if you're looking at it and you're like, I can't find the answer, look at his PowerPoint and they're kind of a mix of both. Okay, what time is it? 9, and we go till, okay, I'll go for a few more minutes and then we'll take a break. Okay, so hypertension. So treatment, pharmacotherapy, lifestyle modifications, those are the two main treatments. And then the next set of slides here is heart disease. I wonder if I can get through this. So it accounts for about 40% of deaths in the US is heart disease, and that's sort of an umbrella term, leading cause of death under the age of 65. So atherosclerosis, so I highlighted this. You want to know this definition: the thickening of the internal layer of the arterial wall caused by an accumulation of lipid plaques. So that's that atherosclerosis, not arterial sclerosis. And that's pretty much what we just talked about in this is athero. Results in a diminished blood flow and oxygen supply to that portion of the heart or the myocardium. So if one area, it kind of chokes off one little area of the heart, and that's what causes some pain. Sometimes it's pain upon exertion. And then it's also called coronary heart disease is another name for it. Cholesterol's role in heart disease. So just briefly, we'll talk about lipids, lipoproteins, triglycerides, and cholesterol. Kind of just, you don't have to, we're not going to go into great depth about this part. We just kind of have some overview understanding of it. So lipids, of course, are fats. They are important in our diet. We know that they help, there's some fat soluble vitamins. They help us, they're insoluble in the blood, so they're transported in the blood via lipoproteins. So that's how that's how they travel, is through a lipoprotein system. Lipoproteins, they're complexes containing different percentages. So this is where we get the different types of, if you ever have a cholesterol, like your blood cholesterol taken, and they'll give you ratios for HDL and LDL and triglyceride and cholesterol. So they have different percentages of these things: triglycerides, cholesterol, proteins, and phospholipids. Triglycerides are synthesized in the liver. We don't need to know much more about triglycerides than that. And then cholesterol mostly is obtained from the diet, but it is made in our liver. So that's the thing. It's like we make cholesterol because it's important for aspects of our cell membrane and different things. There's a function for cholesterol, but if we have too much of it in our diet and our body can't process it very well, then we can get into trouble. You can also, some people can have sort of a genetic disposition to kind of increase cholesterol. I think I'm actually slightly at risk for having higher cholesterol. And so I have to be really careful and eat lots and lots of green vegetables because I'm actually just naturally predisposed to have higher cholesterol. So it's mostly obtained from diet, but your liver makes it. So your liver can make too much. Stress can also affect it too. Keep your stress levels low. So these are the different forms of the lipoproteins. We have the VLDL, which I never really heard much of that before this course, but it's very low density lipoprotein. LDL is low density lipoprotein, but VLDL is very low. Triglycerides and cholesterol are transported in the blood in the form of these very low density lipoproteins. And then the LDLs, that's the highest amount of cholesterol is carried by our LDLs. So it's carried in the blood. So if you have a high number of LDLs, then they're kind of more concerned. And that's predominantly what the statin drugs kind of focus on, is your bad cholesterol or your LDL. So that's what the statin drugs are trying to clear that out. HDL, the high density lipoproteins, those are called your good cholesterol. And that's because that transports cholesterol to the liver where it's eventually removed from the body. So the HDL helps get rid of excess that you don't need. And so that's why they call it your good. So if you have higher HDLs in your panel, your blood panel of your cholesterol, if you have it tested, then they're like, oh, good, you have higher HDLs. If you have higher LDLs or triglycerides or just overall cholesterol, they're like, yeah, not so good. So that's what they're looking for when they're doing those tests. And they actually do that on kids nowadays. My little one, when she was at the pediatrician, they prick. Has anybody with kids they pricked her finger and did a cholesterol check? Did anyone else have? They're doing that with kids now. I didn't know that until we went to the pediatrician the other little while ago. Okay, so cholesterol. So these are some schematics of the different lipoproteins, and you can see HDL, this kind of light blue is protein. And then this kind of, which colors, right? Yeah, this is protein. This is cholesterol. This is phospholipid. This is triglyceride. And so this is the one that carries it out of the body, and this is what we want more of. And then you can see how they call it different names just based on the percentages. And I'm not sure how that actually lines up, but you guys don't need to know that for any tests. It's more just sort of information. You don't need to know those percentages. That's not going to be on an exam. What could be potentially on a quiz or an exam would be, let me get my mouse back over here. Could be some things here like what the highest amount of cholesterol is carried by. So it might say something like what lipoprotein carries the most amount of cholesterol, or which lipoprotein transports cholesterol out of the body. So those are some things that you'll want to know when it comes to lipoproteins. Just another little picture here that kind of diagrams it out. And this video is just a 2-minute video showing how the low density lipoproteins build up in them.
Are the very low density lipoproteins, are those considered fat?
The VLDL, I'll say yes, but it's sort of an educated guess. I've just always heard LDL is the bad cholesterol. So I don't know if in general they lump those together, and then they just, for layman's terms, they say LDL, and they might also consider VLDL as part of it. I'd probably have to do a little bit more digging on that, but I do think that I would just guess and say probably so. Yeah. Yeah. Mm-hmm. Yeah, they have a higher rate of the triglycerides. Yeah, it does look like that with the VLDL and the LDL. Mm-hmm. And triglycerides is what they always say, like we're not supposed to eat, right? Isn't that the trans fats, and they're I don't know. I get trans fats and triglycerides maybe mixed up. Maybe I'm mixing terms, but okay. So here's just another little bit of a diagram talking about the formation of these lipid plaques on the inside of the vessel. So inflammation plays a part of this, and we don't really go into that. But the reason, we get sort of some buildup and some inflammation inside the vessels, and they kind of almost are like little tiny cuts inside of the vessels. And that's what sort of starts this whole process. It gives some clotting and some, something to cling to. And then the plaque builds up there even more. And so it's sort of a little bit of a spiral that starts happening. But overall, what's happening is you're decreasing the size of the artery, less blood flow, less oxygen. I watched an interesting cardiologist talk about how slow buildup of plaque on the inside of the vessels is not as bad as, there's like a couple ways plaques can form. And if one way, if it forms and like a piece knocks off and floats and then gets stuck, like that's way obviously more dangerous than if it's just sort of like a slow occluding of the vessel, because like your body adjusts to it. It's still not probably like ideal or healthy, but your body sort of adjusts to that pressure change. Whereas if it's like a chunk and then the chunk breaks off, so there's different kinds that some can be more dangerous than others, but that's just a side note. You don't need to know that for an exam either. And then this is just another diagram that's showing that when blood flow is decreased and the demand exceeds the supply, then you get the angina or you get the pain. So this is just blowing up like a little area where there would be occlusion in the artery. So then blood flow can't get down to this area. So it's here, it's kind of showing it inside like a cross section of the muscle, the myocardial, and just saying that, within a certain amount of time, this area is going to die if it doesn't get oxygenated blood. So that's sort of like the end result. These are some risk factors here: male, older, family history, high cholesterol, kind of chronic high cholesterol, hypertension, smoking, physical inactivity, and diabetes is something that heart disease and diabetes, oftentimes there's a lot of crossover there. So we always have to a lot of times our diabetic patients will be on cardiovascular medications. Okay, and then these are, I actually think I'm getting close. No, I think there's still a little bit more. I'm just going to go through 2 more slides, then we'll take a break. So here are some different treatments. Obviously, there's the the drugs, the medications, pharmacological management. There's reducing risk factors, addressing lifestyle issues. And then there's some surgery. So coronary bypass, they may harvest a vessel from the leg and patch it into the heart. You can have a stent or an angioplasty, either a balloon or sort of this mesh that opens up the blood vessels. And then the next slide just shows there's the bypass or the stent, kind of a little cage. And then, and this is what Dr. Baggert was talking about, that since it's not smooth, they'll be on blood thinners because they need to be able to flow past that little mesh without getting hung up on it. So oftentimes patients. Oh, okay. And then we'll take a break and then we'll finish up with the last few slides. So we can, let's see, we'll come back at 9:30. Okay, so we'll go on now. There's just a few more slides, and then I'm just gonna kind of draw your attention to a few things. I think what you might find is that more of the handout is focused on his presentation, because all of this is sort of background, what's happening with heart disease. Like this is a very, very, very overview of heart disease. But then the oral medicine part is all really what he talked about. And that's really what this class is, right? Is oral medicine, the medicines your patients might take, side effects that you might see in the chair. And that's all that has the real application. So definitely, I mean, it's good that you know what we're reviewing today. There's certainly important stuff, but I think the heavier hitting stuff is probably more on his slides, because that's more application-based, what you're going to actually be needing to know as clinicians, right? Okay, so just a few more conditions here. So angina pectoris, when the blood flow is decreasing, the demand exceeds the supply, the outcome is, they call it ischemic pain, ischemic pain, and that's the pain that they feel is the angina pain. So characterized by an aching or a squeezing pressure or a tightness in the chest, Pain sometimes radiates to the left or the right, the neck or the jaw. And a common medication for this is the nitrate. So patients oftentimes have their own bottle. We have it in our medical emergency kits. It expires really quickly after it's been opened. But if patients have angina, they have it with them. It's like someone with asthma needing their inhaler. It's if they don't have it with them, it's surprising. And they can tell, if something's come on, and I've had patients pop one. And usually that is good. If for medical emergencies, I think this might overlap medical emergencies and special needs, but knowing the sort of the normal routine of how often a patient can take it. So they can take up to 3 before you call EMS. So that's nothing you need to know for this class, but just being aware that that's always going to be something that's going to keep coming up in different classes. Yeah. Yeah, nitroglycerin tablet is one of them. I think there's a couple different, but nitroglycerin tablets is what we usually think of when we say nitrates. But I think on his slide deck, he had a few different medications, but in general, knowing that for angina, the main, if it's just something that happens, the patients will have nitrates or nitroglycerin. They might also take other cardiac medications too. They might be on like a calcium channel blocker for opening their blood vessels. There might be other things that they take like daily, but if we think angina, your brain should immediately go to nitroglycerin and nitrates.
I have a question.
Yeah.
What is the difference between angina and a heart attack?
Well, it's sort of like they're feeling the pain of the squeeze, but things haven't totally occluded. A myocardial infarction is like it's no blood and oxygen is getting there. So you are in a bad zone, where angina is like everything's still kind of working. Your heart's just kind of like, ow, that doesn't feel so great.
Is that like the thing when patients get it when they try to inhale and they get that sharp pain?
It can happen more under stress. It can happen like, say they've climbed the stairs and they get under exertion. But in our chair, we might see it if patients are feeling very nervous, if they were rushed to getting to the appointment, and it might trigger an angina attack. So it's kind of like a cramping sort of, I would think of it like a muscle cramp, or, I don't know if that's really a good analogy, but a heart attack is like blood flow has stopped to that area and they're in danger of the heart dying, the part of the heart dying, where angina is just kind of like, they're feeling the pain of the squeeze of not getting enough blood flow. So they take the nitroglycerin and it opens everything up real fast. And they get this kind of rush. And a lot of times, I think he was saying, like, if they feel, Dr. Beggert was saying, like, if they feel that rush and they feel like a headache, that they know it's working because all their blood vessels just opened up real fast. And so that helps the pain, because that's what's painful, is the squeeze of the blood vessels, your heart not getting quite enough oxygen to the heart. Answer is not working. Okay. Congestive heart failure. Heart failure is the most common Medicare diagnosis. You don't need to know that for an example. Statistics under Medicaid providers, that's most commonly diagnosed as heart failure. Heart failure is primarily a condition of the elderly. 5 million people in the US have heart failure. So just some statistics there, not necessarily anything you'll be quizzed on. Any condition that causes myocardial necrosis or produces chronic pressure or volume overload and myocardial dysfunction. So heart failure occurs when decreases in contractility, so your heart's not contracting as well, prevents the heart from pumping forcefully enough to really get blood through the system or to meet the demands of the body. Decreases in cardiac output activate reflex responses in the central nervous system, which attempt to compensate. So they attempt to kind of compensate for this, for the reduced cardiac output, such as increased heart rate. So if your heart's not pumping hard enough, it might try and pump faster to try and make up for it. increased preload that results in edema. So there's going to be a collection of fluid. That's the edema, is fluid accumulation. And ultimately the heart fails if nothing is addressed, at some point. So there's some causes here. There's different causes, like there can be, chronic hypertension or chronic heart disease with, plaque, high cholesterol and things like that, causing issues that eventually lead to congestive heart failure. Signs. So when they say congestive heart failure, a lot of times I believe, and this is just from what I gathered from my readings, but when they say congestive heart failure, they sort of mean the whole thing. They mean the left and the right ventricle, the kind of the whole heart. But people can have like left ventricular heart failure or right ventricular heart failure. They can have one or the other. But I think when they just say it, then a lot of times they might be experiencing both sides. So a lot of these signs are sort of a mix of both. But in the notes, I've divided it a little bit better. So if somebody is having left ventricular congestive heart failure, their signs are going to be cough, dyspnea, or shortness of breath, especially upon like exertion, or if you lay them back. So patients that don't lay back well and are just like, can't breathe as well, or they cough and stuff, they probably have some kind of, they could have the whole thing, but they could definitely have some kind of left ventricular heart failure. Blood can't leave the heart very well. So there's a backup in the lungs. So everything kind of, their lungs and everything up here is sort of affected. If it's the right ventricle, then they'll have more fluid retention, sort of the lower half of the body. So abdomen, liver enlargement, pitting edema, swollen legs. So that's sort of an accumulation of fluid in the lower half of the body. But this kind of signs and symptoms, this is kind of talking about sort of all of it. Perceived dyspnea, the shortness of breath, exercise intolerance, fatigue, edema, weight gain, or increased weight in the abdomen specifically. There's a picture of that pitting edema. You kind of push on the tissue and it leaves sort of a little imprint. And so that's showing fluid accumulation. And so for treatment, so obviously these underlying conditions such as hypertension, atherosclerosis, diabetes, all of these are going to be, they're going to have to be taking medications for all of these. And then of course, we're going to try and address behavior modifications such as smoking cessation, weight control, exercise, rest, stress management, probably too, avoidance of alcohol, and possibly restriction of salt in the diet. But so congestive heart failure is usually typically kind of a mix of other things going on that have led to it. Really important here, he didn't touch on this at all. And so this is the one medication that I am kind of making sure you guys, you'll see this medication on a national board. Somebody will. You don't all get the same questions, but I know somebody's going to see this on a national. So I noticed he didn't talk about it, so I wanted to make sure to bring it up. So a possible medication that someone in congestive heart disease, these are some medications that likely they could be taking diuretics. If it's just mild congestive heart failure, they may only be taking diuretic to deal with the excess fluid. But then another very common medication to increase heart contractility, so to increase the stroke strength of your heart muscle, is digitalis or digoxin. There's sort of an overlap here. I've heard people they're not the same, but very similar. And so this is digoxin or I don't often see this written, lanosin, I don't know how to say it. But definitely you'll see the term digoxin or digitalis. So when you see those terms, think congestive heart failure and then think side effect of gagging. And why is this? And this is because it affects the GI. It makes the GI more sensitive. So patients, it causes a lot of GI side effects, the digitalis and the digoxin. So people who are taking that medication tend to be more gaggy. They just gag easier because of that. So that's just one of those things that you kind of want to star. They might also be taking vasodilators, ACE inhibitors, beta blockers, or some kind of other sympathomimetic medication. So there's lots of different medications that someone with congestive heart failure may be taking. And I wanted to highlight that. Okay, so discussions for next week. So answer these questions on your own. These could easily pop up on a quiz. So what type of cardiac medications can cause gingival enlargement? We talked about that in the beginning. What type of cardiac medications can cause a Lycanoid reaction in the mucosa? That's on his PowerPoint slides. And you know, what is a Lycanoid reaction? That's just, it's not a true like lichen planus, like what you might be learning about or have learned about. It's kind of, they call it Lycanoid because it sort of looks like lichen planus, but it's just, the tissues just have this lacy sort of fluffy look. So for the what is a Lycanoid reaction, that's not necessarily a question that I would put on a quiz. That's just more like, I want you to think about that, what it looks like and that sort of thing. And then how many cartridges of local anesthetic can be safely administered to a patient with a cardiac condition? And that's pretty much 2. So there are doctors who might, if somebody's very stable, mild something, a doctor might end up giving more than that. Very oftentimes we don't need to give more than 2 to anybody, 3 max. Like we don't usually give more than 3 carpules. So if somebody has congestive heart failure, and certain medications, like as you go through his PowerPoint and as you look, I will also say, don't just rely on the PowerPoint. Look at the textbook and highlight some of the, you know, there's some really good information there about what medications in particular you want to think about when it comes to local anesthesia. When you take local anesthesia this summer, they'll of course highlight them as well, but just, you know, make sure you're at least skimming this chapter. I think, what is it, chapter 11? I think it's chapter 11. Make sure you at least skim it, whether, you know, if you don't like read every word, but just there's some good information there. But in general, 2 is sort of the magic number for patients that are cardiac patients. And that's it for that. So now I'm just going to pull up, because we have we have actually more than a few minutes, but this will probably only take us till 10. And then we'll be done a few minutes early, so you can just go get a tea or a coffee or something. But let me pull up his PowerPoint quickly. Yeah.
These are all.
No, I'm sorry. So sorry, you guys. So that last slide that says CHD possible medication, it's kind of saying the main bullet points are different medications that they may be on. So they may be on a diuretic, stop. They may be on a drug to increase heart contractility, which is digitalis digoxin, stop. They might be on a vasodilator, stop. So those are all different categories of what. So yeah, so I didn't really list any diuretics there at all. I'm just saying they may be on a diuretic. That's actually very common because of the fluid resistance. Diuretic. There's the loop diuretics. There's a, if you look, actually, let's look here real quick. We'll pull it up. Let me pull it up on his. It probably is. I think there's a lot of this is on his. So, so see, there's thiazide diuretics, there's loop diuretics, and there's potassium sparing diuretics. So you might get a question. This is a good thing to star this. You may get a question asking about the classes of the diuretics, and it might throw a curveball and name something that sounds similar, but not quite that. So this is what it wants you to know. So Hydrochlorothiazide is a medication you guys are going to see, HCTZ, although he did say that it's not being as prescribed as much, but is a very common one to see, HCTZ, hydrochlorothiazide. But that one, LASIK is a common one, furosemide, and then aldactone, I haven't seen that one as much in practice, but it's certainly out there, I'm sure. But these are the three categories. So thiazides, loop diuretics, and then potassium sparing diuretics. So just think potassium, loop diuretics, thiazide. So that's one thing. So classification of and then things that might come up are going to be mechanisms of action. So, diuretics, a main mechanism of action for diuretics is to, water goes where sodium goes, right? So excreting water, so that sodium, so that the water follows. So we decrease the blood volume or decrease accumulation of fluids in the body. So knowing the mechanism of action of drugs is going to be important, possibly more important than knowing like every single drug in a specific category. So let's look at another one here. Okay, now look, for instance, see how he's highlighted allols. So make yourself a little flashcard, beta blockers, other side, allols. So if you know that, and the same thing with calcium channel blockers, other side of the flashcard, if that works for you or however you want to do it, is the pines or the penes or whatever. So that's what I mean by the suffix. You want to know, sorry, my little pointer is in the wrong place. So you want to know the suffix here. So mechanism of action for beta blockers: reduce heart rate by blocking effects of the sympathetic system, produce peripheral resistance via decreasing the renin activity. So the beta blockers are going to interfere with that whole RAS system. So it's decreasing renin from the kidneys, and that's what kind of starts that whole system going, right? So it affects it affects the beta 1 blockers in the kidneys. Also affects the beta 1 on the heart, and if it's non-selective, it might also be affecting the lungs if it's beta 2. Sorry, Jenny. You're doing great, Jenny. You got this. Your brain's about to explode. I know, everyone. We're almost done. So, okay, I wanted to just highlight a few things so that this is for your help. This is to help you for the upcoming exam and quiz. Okay. We are in, I'm just flowing through his PowerPoint, highlighting some things that I want you guys to make note of. So this is just, I'm just in his PowerPoint right now. So he's just showing how things block. This is just him reviewing the different medications and how they block. So I'm just kind of going through this here. Works on the beta 1, but not the other receptors. Sorry, kind of drawing. I like all his animations though. And then propranolol is just showing how it blocks beta 1 and beta 2. So this is non-selective. The other one was selective because it only did beta 1. So these are just some of his main points. Okay, ACE inhibitors. So knowing that the ACE inhibitor reduces production of angiotensin 2. Note again, oh, sorry, my little pointer is in the wrong place. Note again the suffix. ACE inhibitors are prils. So you don't have to memorize every single medication that's a pril, as long as you know that prils are ACE inhibitors. That just helps. It's like a shortcut, right? So prils inhibits angiotensin converting enzymes. So it inhibits ACE. It reduces production of angiotensin 2 because you need ACE to get to angiotensin 2. Also important to just, he's got some great side effects here, like with the cough and stuff. But the one thing that I do want you to look at that I think is super important in the textbook, everybody has access to the textbook, right? So No. And if you don't, go find a friend that does have one. But there's a chart in there that talks about the NSAIDs and the orthostatic hypotension. And so it lists like gobs of medication. I don't have my book, it's in my office. I would pull it up. But it lists like gobs of high blood pressure medications. But then next to it, it'll say like caution with NSAIDs because it kind of reduces the effectiveness. Orthostatic hypotension is on a lot of these. So remember when we're dealing with our patients sitting up slowly, and then it might say something about local anesthetic, or it might say something about gingival enlargement, or it might say something about xerostomia. That is just a great chart to look at and note the ones that stand out. So for instance, calcium channel blockers are going to stand out because it's the only one that's going to talk about gingival enlargement. So he's got some good information here, but the textbook, being a dental hygiene textbook, is going to fill in a few blanks that he doesn't put in his slide deck. Okay, and then so suffixes, I already talked about suffixes. Which medication causes hyperplasia? I talked about that. Mechanism of action for diuretics, I talked about that already. Common dental implication is the orthostatic hypotension, so I kind of just talked about that. And then what influences blood pressure? Those three things that influence blood pressure, that's in my PowerPoint, I think. So the peripheral resistance, the volume, the blood volume, and now I can't remember the third. You'd think I would have it all memorized. I don't. Yeah. The suffix for diuretics might not be, there might not be a good, that might be a funky one because it has it's like, well, unless it's "ide" or "zide." Let me see. Did you see that? Oops, too far. Yeah, so there's I think it's not a good, there's not a good sheet for that one. And you will notice, like if you look up this, if you compare this information in, again, our textbook, you will notice that it's not always perfectly aligned. You'll get tested on the ones that are the most common and the ones that sort of fall into these categories of the olols and the preens and the primes and the trills. So you'll get tested on those, but you'll notice that there's other drugs that don't line up and end in something else. So it's not always 100% perfect that way. And you're right, the diuretics don't really have a suffix to go off of. So yeah, so that's it. So those things that I just kind of hit on are all things you're going to want to make sure and study for future quizzes and exams. And those questions at the end of my PowerPoint too. And then just making sure you go through the study guide and then that chart in the chart in the text that talks about the dental implications. Yeah.
You probably said that too, but I just want to make sure. So is this PowerPoint very similar to the one that we just covered right now? And then we can go back to this PowerPoint into medications that were highlighted, so I don't focus on the perfect just over.
This is the one I think that you're actually going to find more answers for the study guide. This is Dr. Beggart's.
Like about the same information as the one that we just covered from the beginning of the class.
Today.
Yeah.
It parallels it in the way that I talked about sort of the condition, and then he's talking about the medications. So they parallel each other, they go hand in hand, but they have fairly different content.
So go back to his PowerPoint.
Yeah. Yes. Dr. Beggart's for the medications, mechanism of actions, the medications, side effects. But then I also say because he's not a dental hygienist, he's put in a lot of good side effects. But if you scan your textbook or at least look at those tables, there's a couple big tables that take up 2 or 3 pages. They're blue, it's like blue, and it lists all these medications. And then it talks a lot about side effects. So that stuff's really important for you guys to know because totally hand in hand with your work as a clinician. So it's super important that you know that. Yes, just watch it over and over again. So if you struggle with this information that's the stuff that he presented last week, definitely watch it again. He only talked for 45 minutes, so it's not a horribly long video. And it's well worth watching it again because I think you'll find a lot of this information in his talk. And then the PowerPoint that I went over this morning is also important, but I think more of the stuff that you'll be tested on is going to come from his. Because just as I kind of was reviewing several things that I wanted to highlight from his, you know, they're all mechanism of action and things like that. So side effects are any side effects that affect clinical practice or a patient's oral health is always important. Always keep those in the forefront of your mind with any topic. Next week is, I think it's respiratory. So, you know, lots of dry mouth, taste alteration, things like that and it's always going to be. And then we're going to repeat it again in special needs. They say, okay, this is how, remember what we talked about in oral med for our patients who have asthma. This is what's important. And these are the kinds of things that you have to deal with in clinic. And so try and give it more of an actual like hands-on, realistic kind of application once we get to that point. But we just kind of revisit all these things. But side effects are always important if they're affecting the oral health. I never use that thing, the microphone. Can you guys all hear me okay? Okay. I always feel bad. I just forget. I never think to put that thing on my head. Anybody have any other questions? I am in no hurry, but I know you guys might want a little extra break. And you're like, catch me in like, you know, tomorrow or something. Yeah. So next week, so just last thing. So next week there is a 10-question quiz. It'll just be multiple choice and it will cover this material. So it'll cover fair game, his PowerPoint, my PowerPoint, but I'm going to throw in and pay special attention to those last few questions at the end of my slide. Those are going to probably show up at some point for you. Hint, hint. And then also I'll probably throw in at least 2 or 3 questions that I talked about in the beginning that you guys needed a little bit more review. So that should kind of give you, yes, the ones that were missed from the exam. So that should give you a good idea about 7-ish questions that might be on the quiz this week. So, you know, just to give you a heads up.
What was the immediate presentation of cardiovascular?
That is something that I actually created that when I was teaching it last year to almost help myself. You don't need to look at it for test questions. There may be some helpful, it might be explained differently, or there might be just, you know, look at it for sure. That's why I kept it in there. But it was just me sort of like going through and sort of getting it all straight in my head. And then I just posted it. So yeah, that's just sort of, it's a repeat of a lot of things. And it might, I haven't even looked at it yet this year, so I don't 100% remember, but it might have assimilated some of his and mine. Yeah, yeah. So it's just an extra thing to look at. One more thing to look at. Not for the quiz, not for the quiz. Maybe for the, I haven't decided for the exam, we'll see. But not for the quiz. The quiz is totally, it's going to be the first quiz that's going to be in class. Hopefully. Yeah, hopefully, barring any major problems. Yeah, so no quiz, no help on this next quiz. So this will just be all your memory things. Because remember, you know, quizzes are supposed to like gauge, like, okay, if I can do pretty good on the quiz, then I got this, I got a handle on it. It kind of gives you, it's supposed to be a gauge to help you know how well you're getting the material so that once you take the exam, you know.
I meant for the exam.
Oh, yeah, maybe. I haven't decided. We'll see. I'll let you guys know. Okay. So you guys are free to go. If anyone has any questions, you can still come up and talk to me if you want. But other than that, you are free to go. So just note Lycanoid reactions in the diuretics. Notice that, just FYI. See how it says Lycanoid reaction at the bottom of the slide? And that's with the thiazide and loop diuretics. So just one of the questions was talking about like Lycanoid reactions, what medication causes a Lycanoid reaction. So just knowing it's the diuretic. Yeah.
I had a question for so in the last exam, the protein one.
Yeah. Hold on
Could
just
you
a
explain
second.
again? So the question was asking, I already forgot what it was.